Good afternoon, everyone. I'm Rakshya Upreti. I'm one of the trust grade doctor currently working in Department of Obstetrics and Gynecology as a registrar. Today, we are going to present our survey, which was a point prevalence survey on hospital-acquired infection and antimicrobial use that we conducted in our trust, Ashford and St. Peter's NHS Foundation Trust. This was a part of the 6th National Point Prevalence Survey that was conducted in 2023. We all know that the National Point Prevalence Survey on healthcare-associated infections and antimicrobial use has been ongoing in England for the last 40 years. The first one was in 1980s. So this survey was a part of the, as I've already mentioned, part of the 6th National Point Prevalence Survey, and almost 124 different NHS Foundation Trusts and other organizations has participated in 2023 in this survey. The last date for data collection was on December 7, 2023, and more than 56,000 patients were involved in the survey. The result of the national survey is still not out yet. It will be launched probably in next coming month through webinars, and it will be disseminated through conferences throughout the nation. So we will be basically talking about the methodology, how we conducted the survey in our trust. Before conducting the survey, we defined hospital-acquired infection based on the PPS protocol on antimicrobial use and hospital-acquired infection 2023, which says any patient with signs and symptoms of infection or who had the signs and symptoms of infection in the past but are still on antibiotics. And the other criteria, the most important criteria, is the signs and symptoms to develop after 3 days of admission into the hospital. However, if it is a case of readmission, then they should be readmitted with less than 48 hours of previous admission to an acute care hospital with signs and symptoms. Apart from those criteria, we also included patients who meet the definition of active surgical site infections following a surgery within 4 weeks after the surgery, or if they were on any invasive devices or such as intubation or IV cannulation, central venous line or catheter, then they should be developing the signs and symptoms of infection within 48 hours of insertion of devices. When it comes to the Clostridium difficile infection, any patient who has been admitted with C. diff infection less than 28 hours after previous discharge were included in the survey. We all know that hospital-acquired infection is one of the cause of major morbidity and mortality. If we look into the data, we found out that every year in Europe, there are 4 lakh cases of hospital-acquired infection every year, with 37,000 deaths each year, which is actually a huge number. So there are different strategies. However, we can prevent the number of deaths from hospital-acquired infection if we can follow these strategies, and we can see that surveillance is one of the important aspects for prevention. We all know point prevalence, which determines the number of cases at a specific point or a period of time among the total number of population we are studying. So the point prevalence survey on hospital-acquired infection was an important data collection tool to identify the hospital-acquired infection for our survey, whereas when it comes to the antimicrobial use, we were able to collect information about the prescribing practices of antibiotics and the antimicrobial consumption. If we look into the literature of the previous survey, we can see that the first survey in 1980 shows the prevalence rate of hospital-acquired infection was 9.2, which was gradually decreasing. And on the last survey, it was 6.9%, which was conducted in 2016. The result of 2023 is not out yet, as I've already mentioned. When it comes to antimicrobial prevalence, the percentage rate of the antimicrobial prevalence on the last survey was 37%. The primary aim of our survey was to estimate the point prevalence rate of hospital-acquired infections and antimicrobial use. However, we also described the patients based on their comorbidities and demographic parameters, any invasive devices inserted. We also describe different types of infection based on sites and microorganisms, and we have also describe antimicrobial, prescribed based on the dose, route, and types of antibiotics prescribed. When it comes to when looking into the methodology, we included all the patients in all the wards of our hospital, including surgery, medicine, gynae, ICU, and also the working community health center. So all the patients that were in the ward between 8 a.m. and 8 p.m. were included in the survey. Any patient before 8 who were admitted after 8 a.m. or discharged before 8 p.m. were excluded. When it comes to the neonates who were born before 8 a.m. on the day of survey, they were included as separate entity from the mother, and they were also included in the survey. We excluded any patients who were admitted for day case procedures or day case surgeries, or any patient in the emergencies, or any patients on ambulatory care, or any patient attending for dialysis, or any patients who were admitted on the same day but after 8 a.m. The remaining of the data structure and methodology will be explained by my colleague.
Hello, good afternoon all. I know we all come from different NHS trusts, and we all come from different backgrounds. And I just wanted to know how many of you here has by any chance participated in this survey? Okay, there are a lot. Nice to know that I can see many people who have contributed to this survey. Actually, we are presenting this to tell how we did it, the methodology, that how we collected the data and other stuff. Most of you would have known that we need to collect data from wards, the base details from the wards, like total number of beds, number of side rooms, single rooms, number of beds with equipped with sanitizers, and number of healthcare workers at the point of survey. And the denominator and numerator data that we collected after going to that, before starting the survey, actually, I would like to say that we were around 15 doctors who joined the Ashford and St. Peter's Hospital at that point in time as clinical attachment doctors. And then this survey was about to start at that period. And then our mentor has divided us into 5 different groups, and each group had 3 doctors, and there are around 20 to 21 wards in our hospital. And each group of 3 doctors collected data from 2 to 3 wards within 2 to 3 weeks period time. That's how we did it. And then we have a software Cerner. It varies in different NHS trusts. And we went into the ward and looked at the base details, and then from the same day, total number of patients who can be included, we collected the data from them. Their basic details, there are 5 forms. You all would have known that there are 5 different forms which we have to go through one by one to collect the data. So inclusion on antibiotic therapy as well, we included if the patient was already on antibiotics before 8, and if it was started late after 8 p.m., we didn't include them, and exclude the antibiotics if it was stopped before 8 a.m. on the same day. And if the patient has received single dose of antibiotics within 24 hours, we included them under antimicrobial usage. So hospital coordinator, we had a mentor, Dr. Ashwin. He helped in, we actually mailed each wards saying that we will be coming for the survey within this period, 2 to 3 weeks time, to collect the data, and we got permission from the ward manager. And then as I already said, a team of 3 doctors went into each ward and collected data from each specific ward. Before starting the whole survey, to understand, because it's a very big protocol book and it's sometimes really very confusing what it is. So we have to discuss with our nurse practitioners who are involved in infection control, and also we had multiple discussions with microbiologists, and our pharmacist Nikki Lewis, we have mentioned earlier. She also helped a lot in understanding and how to look at data from the Cerner software to see whether the patients are receiving antibiotics or not, so that we should not miss on anything. In the pilot study, we did it in an orthopedic ward where three of the doctors initially just try to assess all the patient on the same day in that ward, and then we try to first get an idea of how to do this survey. There were sessions previously conducted, we know that, and then we gone through the videos as well to get an clarity about how to do this survey. And then after we collected the data for that particular ward, we try to do the initial analysis about there are about 40 patients in that ward, and then we try to look at what's the prevalence in that specific ward, and then we had a discussion with our colleagues as well, the other four team, like how to go about and data collecting and entering into the Excel sheet. So this is the sampling methodology, like 5 groups of 16 medics across countries, doctors. Time frame was 3 weeks. Total wards covered is 20. We included Ashford as a different hospital. We have 1 ward there as well, and Woking Community Hospital as well, we have 1 ward. So we included those 2 wards, and then we included all the wards in St. Peter's, which is the biggest hospital for us. We try to achieve 100% data accuracy. So this methodology, most of you would have gone through how we all collected data. This is the same thing which I was talking about earlier as well. So after collecting the data, we try to go through each other's Excel sheet to see whether is there any mistakes in data collection, whether we have missed out on some antimicrobial usage, or did we miss to term them as a healthcare-associated infection. First, we did it within groups. We tried to do one validation, and then again we took the help of a microbiologist and infection nurse practitioners to go through our filter our data, and then like clear the data that we should not miss out, or we should not add extra things into that. And then we used SPSS just to do some basic analysis. And we found out that in a hospital, healthcare associated infection was 9.9%, even though the national prevalence is around 6.9, but in our hospital we found it was 9.9, and antimicrobial usage was around 37%. So, we all know that purpose is to monitor rates of antimicrobial usage within and resident bugs in the hospital, and to check whether which trust has more healthcare associated infection or which has less, and how they are performing better, and to interchange practices how they are performing better, and to identify targets to improve antimicrobial prescribing, and to help designing hospital interventions to promote antimicrobial resistance and usage, and to assess the effectiveness of interventions through repeated point prevalence survey. So these were our references. So these are the data collection different sheets. Yeah. Thank you.